Good afternoon, everybody. The topic of my presentation is comprehensive audiological assessments, and with a focus to what should be the assessments done prior to cochlear implantation. Just like in the panel discussion, Dr. Oza mentioned that it is very much necessary to have a complete audiological idea about the child's hearing status, which will help us to make better decisions regarding the amplification or cochlear implantation. So the first question is, why do we need these audiological assessments? We need to have a clear understanding of the site of lesion, the degree of impairment, which will help us to make decisions regarding management options and also help us to have realistic expectations about the child. The challenges which we face today are to know the type of loss. This itself has undergone a radical change in the few years, where earlier we were happy to know only whether the loss was conductive or recent. Today we need to know not only whether it is cochlear or retrocochlear, but also whether the site of lesion is at the outer hair cell or the inner hair cell, or the synapse of the inner hair cell and the auditory nerve, or the nerve itself. We also have the challenge of knowing the accurate degree or threshold estimation and the configuration, which will help us in good digital hearing aid fittings. Further challenges to have ear-specific and frequency-specific information, but in a very young child whom we want to test very quickly, so need to have quick but valid test is important, which brings us to the important concept of having a choice of test which is practical as well as valid in getting us good diagnostic decisions. When we talk about test selection, I would again like to reinforce the fact which knows that audiometry is always the test of choice, because it does provide us with ear-specific and frequency-specific information. We get to know the type, degree, configuration, which is important information relevant for management. But as this test is not possible before 2.5 years of age, even a conditioned audiogram is not possible. So we come to the other test. Of course, I'll just, all of you must be aware, but quickly I'll go through the conditioned PTA, which we can start at around 2.5 years of age, mental age that is, in which we help the child to associate the sound with a motor response, such as whenever the child hears a sound, he has to put down a peg or something like that, and then we can get information about the thresholds. So we can do this kind of a testing in a sound field, even without headphones, and get an audiological evaluation or an audiogram like this, which can tell us, as Mr. Patadia said, about the speech banana, and how the audiogram fits into the speech banana gives us an idea about what the child can hear and what he can't hear. For children less than 2.5 years of age, we have two types of tests, biophysical tests and behavioral tests. The behavioral tests commonly used are behavioral observation audiometry, wherein we will like to look at the various responses which we just heard from Mrs. Sanghi before. We will like to observe these responses in a child, compare them to the expected responses in a normal infant, and try and get an idea about the child's hearing status. So for BOA, we can use this test from birth to 2 years, where we observe the child's response to a variety of stimuli, and the responses observed depend upon, as ma'am had stated, the different age range of the child. These are the various sound makers that we use in the clinic. These are pre-measured, though they are not calibrated, but they are measured with the SLM, so that we can get an idea about how much the child can hear. It is a rapid time efficient procedure, and sometimes for a severely disabled child, it's the only procedure which we can use many a times. VRA or visual reinforcement audiometry, here we use the process, we use the response of localization of head tone of the child in order to get an idea about how much he can hear. We can use it for children 6 months and above, because that is when localization can develop. And again, we can get ear-specific and frequency-specific information in this test. We place the child in a two-room situation and distract the child and present a loud tone and a visual reinforcer, so that the child associates the sound to visual stimulus. Once the child is conditioned, then we present only the tone and see whether the child is trying to look for the light also, and if a child looks at the light, we consider it as a response. In this way, we can again get a complete audiogram using the visual reinforcement technique. Mostly the electrophysiological tests which have got more information or which are given more importance today, which I would like to stress upon. I am going to talk about the ABR, the ASSR and the OE. So starting with the ABR test. ABR is a synchronous neural activity of the 8th nerve and the neural centers right up to the level of the lower brainstem. It is recorded by placing electrodes on the scalp and stimulating the ear with brief transient stimuli such as clicks. And as a result of these clicks, we see a series of waveforms in the first 10 to 12 milliseconds which can be processed. And the response which we see is a graph of voltage versus time, something like this, wherein we will look for, these are the waves, and as all of us are aware, we will mainly look at the wave phi for threshold estimation. These are the typical click parameters that we use. Of course, different centers can use different parameters, but these are the common parameters which we use, wherein we use 2-channel recordings, and the filter setup which we use is between 50 to 1500 Hz to get a robust response of wave phi in children. We use a 20 millisecond window because in children, as we go on testing, as we come down towards the threshold, the wave phi latency increases, and in order to visualize the wave phi, we use a 20 millisecond window. Using the ABR is mainly for 3 purposes: to know the overall sensitivity, for which click is the stimulus of choice, for knowing the type of loss, wherein we can use both the latency intensity function as well as bone conduction ABR. What we are many times using is the latency intensity function. I will show this later on. This is an example of typical click air conduction ABR, wherein we can see the wave phi being traced at different intensities. Here. As we can see, as the intensity is decreased, the latency is prolonged and the amplitude of wave phi decreases. This is again another example. This is the left ear and this is the right ear. As we can see in one ear, that is in the left ear, we can see the responses right up to 18 dB PSPL. This is a child with normal hearing in this ear. Whereas in the other ear for the same child, the peaks could be traced only at very high levels. And this is the LI function or the latency intensity function I was talking about, where we can plot what is the latency of wave phi at different intensities for the good ear and the worse ear. The good ear can serve as a control, and we can even get an estimate of how much is, what type of loss it is, and to what degree. In this case, we can see that the LI function for the worse ear is shifted to the right. It's exactly parallel, but it is shifted to the right by 60 dB. So we can get an idea that this child has a 60 dB conductive component in the poorer ear. This is the typical no response. We are not even sure about what we have marked as wave phi is truly wave phi, and this child we will predict has a profound hearing loss. In this case, we had an audiogram later on for the child. We showed that what we suspected was true. So in threshold testing, we record ABR at different intensities and trace wave phi, and threshold is the lowest level at which wave phi is detected. In neonatal hearing, what we have observed many a times is that wave phi could not be detected in many children, but wave 3 was very robust. And in many such cases, we have used wave 3 to detect the threshold. Why is ABR the test of choice? It is one of the most robust responses which is not affected by drugs and state of sleep and objective procedure, high degree of reliability and validity. However, it has its own limitations, and knowing what ABR can provide and cannot provide will give us a better idea about management decisions. The test is objective, but the interpretation is highly subjective, and there is need for sedation. Another important issue is that there are false responses, especially if the stimulus that we are using is click. Many a times we see a no response on ABR when it is elicited using a click, but it need not always mean a profound hearing loss as what I had shown you in the earlier audiogram. This is because the click evoked ABR gives us information only in the frequency range of around 2000 Hz to 4000 Hz. It is like having a 1-point audiogram with us, and none of us would like to fit if we have only those two frequencies in our audiogram. So many times high frequency hearing losses or children or infants with maturational delay or those with certain higher order conditions such as auditory neuropathy may show an absent ABR or may not show any wave peaks, identifiable wave peaks when we have used click evoked ABR, and we might be tempted to quickly say that this child has profound hearing loss and may be tempted to make management decisions. However, we need to correlate the ABR with other testing techniques before we jump to these conclusions. Here, because we cannot get frequency specific information using click ABR, one of the things that we could use is using tone burst ABRs, when instead of the click we will use a tone burst, typically a 202 pattern tone burst, and we can get information about low frequencies. Generally we try doing at least 500 Hz tone burst and 1 kHz tone burst along with click ABR so as to estimate a typical audiogram in a child. However, it might be difficult to record the tone burst ABR very much near thresholds, especially for low frequencies. This makes it slightly difficult to use it clinically. Another major limitation which is quite relevant to cochlear implant candidacy is that the range of hearing loss which can be estimated using ABR is limited. This means to say that when we get a no response on ABR, the child could have a loss of 80 dB or 90 dB or 100 dB, or it could be a typical 120 no response child. So the click evoked ABR will not give us an idea regarding whether the no response means severe or profound or a dead ear. And as all of us know, this provides this is a major limitation in cochlear implant candidacy as well as in decisions regarding what fitting should be done for the child. Here is where we can come to ASSR or auditory steady state response, which can be used as an adjunct to ABR, never to replace ABR but as an adjunct to ABR. So what is the ASSR? It is an auditory evoked potential that is steady state. It is in some ways similar to ABR but in quite a few ways different from the ABR, mainly because it uses the stimulus which is periodic. It does not use a click but uses either an amplitude modulated or a frequency modulated stimulus, a periodic stimulus. That means a stimulus which repeats itself over time. What happens because of this stimulus is that there is a response from the different levels of the brainstem or the auditory nervous system which follow the stimulus pattern. So the response which we get is phase locked or a steady state response, which means that the envelope of the response is very similar to the envelope of the stimulus. Now instead, how in click evoked ABR, what we do is we make judgments or we analyze the latency and the amplitude of response. We look for the latency of wave 5, we look for the amplitude of wave 5. But in ASR, what we do is we analyze the response in terms of its frequency domain or the spectral domain and its phase, and try and understand whether the response is present or absent. This is the typical AM and FM. Here both AM as well as FM have been used. This is a periodic stimulus. The carrier is a tone of 1000 Hz which has been modulated at the rate of 90 Hz. It's a high repetition rate. Okay. And the energy is something like this in the stimulus itself. When we analyze the response of such a stimulus, that is the ASSR which we obtain, we can see that the response has various components, maximum at the modulation rate, that is 90 Hz, and also at its harmonics. So in the ASSR, an analysis is done in the spectral domain where we try and find out whether the response is present or not. And another thing which I don't know whether it's a positive thing or a negative thing, depends on how we take it, is that we do not see any response waveform but rather there are the algorithms are present within the computer, and we directly get a response in terms of whether the response is present or absent. Of course, sometimes we would be more confident when we see a waveform to make a judgment, but for most often for screening purposes, this becomes pretty convenient when we have direct answer whether the child can hear or cannot hear. We don't have to look for a waveform. So it's an objective response and frequency specific. In the clinical applications, we use frequencies of 500, 1K, 2K and 4K and can estimate losses up to 120 dB HL. It can be recorded at different modulation rates, and depending upon what rate of modulation is used in the stimulus, we are getting the response from different neural centers. So if lower rates are used, we are stimulating higher portions of the auditory nervous system, and when higher rates are used, when you use something like 80 or 90 Hz stimulus, the activity is from the brainstem, something like the APR, so that it is the response is unaffected by sleep or by drugs or by sedation, and hence when we are using ASSR for children, we need to use high repetition rates or high modulation rates. How is the response measured? The measurement is in some aspect of amplitude or phase. We can see a response here. These lines which are seen, can these lines be seen? These are showing us the response at different frequencies, and the length of this line is indicative of the strength of the response. Okay, so greater the length of the line, greater stronger is the response. Or it can be analyzed in terms of its frequency domain, like this, an amplitude spectrum here, where we can see maximum energy at whichever frequencies. Most of the equipment today have a direct facility in which the ASSR is directly translated into an audiogram, so that for the same case which I showed you in which we saw the phasor plot, we can directly get an estimated audiogram based on the findings. So we can see the right and left ear thresholds being plotted like this, and this is the beauty of getting a response like this, which can really help us in hearing aid fitting or in decisions regarding management. The disadvantage is that we cannot differentiate between cochlear and retrocochlear hearing impairments, and because of this, we need to have this as an adjunct to click evoked APR, not as something instead of it. Coming down to autoacoustic emissions, I'm going to skip these slides of what OAs are, because most of this has been covered with Anuradha. That OAs are the cochlear amplifier. They are the output of the outer hair cells. They tell us about the functioning of the outer hair cells, which are the mechanical amplifiers. And when they are present, when OAs can be recorded, we are sure that at least the OLCs of the child seem to be intact. This is how we record. We put a probe, and OAs can be recorded within this probe. They can be either spontaneously evoked OAs or spontaneous OAs or evoked OAs, and most commonly in the clinic what we use are both the evoked OAs, which are transient evoked, where the stimulus is a click, or the distortion product, where we use tone pairs. In the TEOAs, we look for the amplitude, the spectrum, as well as the signal to noise ratio in order to judge whether the transient evoked OAs are present or not. We need to have an adequate probe fit, and the noise floor should be low, which is a major problem in most of our testings. We need to have a very silent environment, even if not sound treated, we need to have a silent room. The noise floor should be less than 47 dB in order to get a good signal to noise ratio. This is how a TEOA would look. This is the noise floor. The black one is the noise floor and the red one is the response. So we can see that here the response is quite above the noise floor, and if we see the signal to noise ratio in most of the frequency bands, the signal to noise ratio is above 6 dB. So we consider that the child has passed the screening, or that the child has TEOAs present. This is another good response, and this is a no response on TEOAs, where most of the emissions cannot be seen because of a very high noise floor being present. This is a quick test and can help us really. But the important thing to remember is that if the child has any middle ear pathology, even a slightest of conductive loss, then the OEs cannot be recorded, and this is a major limitation of using this tool in the young population who has high incidence of otitis media. In DPOEs, we use two tones, F1 and F2. Yeah. We use two tones, F1 and F2, and the result is that we get the distortion product emission which can be recorded in the ear canal. This F1 and F2, generally what has been found is that the best DPOE is recorded for F1 and F2 which are in a ratio of 1.2, and when they are presented at different intensities of 65 and 55 dB SPLs. So most robust response is found at 2F1 minus F2. This is a response. This is a noise floor, and you can see a very clear-cut response of DPOE in this child. When we compare the use of TEOE and DPOE, again we prefer using both. But what is to be remembered is that TEOE is a quicker thing which we generally more often use for screening, but it cannot give us idea about the high frequency information. So when we want more information about the high frequencies, DPOE gives us a much better idea. We need to reduce the noise in the test area as much as possible and have a good insertion of the probe tip. This is especially important in children if we have to get a good OE response. Lastly, I would like to stress that of course for the want of time, even other tests such as impedance and others were not covered. But what one needs to remember is that no one test can provide all the information in children. Each test is based on physical principle and views the biological system in a very different perspective. So correlating the test findings of a good selected battery is most important. I will in fact go on to say that even when the test results do not tally, it is more important to look at the test results because they may be trying to tell us more about the system. Many times we see children who show no response on ABRs, but when the parents are not confirming with this, and when later on we try and do other tests like behavioral techniques, we see that the child had low frequency better hearing. Or sometimes we may see that robust autoacoustic emissions were present even though the ABR was absent, which in it is a case of so-called auditory dyssynchrony or neuropathy. So we need to have the findings of the variety of tests together in order to reach any conclusion. Thank you very much.
Thank you, ma'am, for the wonderful presentation.